Hello, my name is Uddalak Majumdar and I'm a fellow in the Department of Pulmonary Critical Care Medicine, here to talk about the ventilation strategies in simulated obstructive lung diseases under the mentorship of Professor Robert Chatburn and Dr. Eduardo Mireles. In background, there is a positive original research data and clinical trials to guide mechanical ventilation in patients with obstructive lung disease. There has been a proliferation of review articles which recommend a wide range of ventilator settings, but that has not been studied in any comparative manner. The goal of this strategy is when a patient with severe obstructive lung disease, such as severe asthma or severe COPD exacerbation, gets admitted to the ICU and undergoes mechanical ventilation, is to one, adequately ensure alveolar ventilation while minimizing autopy. However, there has been significant variability in clinical practices in adopting these strategies and also having a pathway on how to ensure these goals. The aim of your study was to understand what combination of ventilator settings achieves these goals. After an extensive research, a set of recommendations was compiled. Expert recommendations from all over the world, including Australia, Europe, and North America, uh, were compiled into a ventilator model. Citations, journal impact factor, different practices around the world, and temporal evolution of mechanical ventilation was taken into consideration. The mode was a volume controlled mode. A wide range of tidal volume and respiratory rate was allowed with a fixed I to E ratio of 1 to 4. Due to this being a simulated study, PEEP and FiO2 did not matter. A patient model was created using parameters that has been studied and recorded and well established in clinical and simulation studies, and this was inputted into a breathing simulator or ASL 5000. After steady state was achieved with 10 breaths of mechanical ventilation, data was collected. Autopeep was recorded at levels of mechanical minute ventilation over a wide range of PCO2. In a patient with obstructive lung disease, an acceptable PCO2 was left between 100 and 40. And we see that autopeep has a linear relationship with minute ventilation. Thus, in this patient simulation model, we see that increasing level of mechanical ventilation by tidal volume and not respiratory rate will achieve the lowest increases in autopeep. Minute ventilation and autopeep have a linear relationship, and from these graphs we can estimate the autopeep for any level of acceptable minute ventilation. Thus, the clinician can also use this graph to change ventilator settings to achieve optimal minute ventilation. To re-emphasize that to increase alveolar minute ventilation, it is better to increase tidal volume and not respiratory rate to minimize autopy. Thank you. Please contact us for any questions.